product came back positive, or PCR product came back positive. So they ended up just having the flu. That's why they were febrile. That's why they were tachycardic. And I was able to stop all the unnecessary healthcare expenditures, stop unnecessary antibiotic usages, and, you know, save the patient 5 days of an ER stay, or not an ER stay, 5 days of an inpatient stay that's not necessary because they had the flu and their clinic doctor didn't have a, you know, accurate product that they were using. So higher sensitivity and specificity than other test methods. That's the PCR, yields highly accurate results, so we can, you know, make actionable clinical diagnostics. It can detect infections beyond the 72 hours of illness onset, so you don't have to get these people very early on in their disease course. You can get them a little bit later if they, you know, took their time at home. A lot of people were very worried about coming to the emergency departments. They were staying at home longer than they used to, so they were staying at home and trying to fight everything on their own before coming in. So having the longer detection window has been helpful. It's still relatively quick. You can have same day patient diagnoses. Most of these tests can come back in 20, 30, 40 minutes. And one of the big ones for me, it does not require confirmation of negative results. I'll touch on this a little bit later, but one of my biggest pet peeves was strep swabs, that people would come in, they'd get a strep swab. This was previous to us having the PCR product. We normally didn't trust the results of these tests that we had were about 56% accurate as the ones we were using. And we would normally treat the patient on a center criteria, let them go home. And then the next day, the cultures would come back that they'd either be positive or negative. And we'd have to waste a lot of time calling patients back, calling in prescriptions to the pharmacies, and just a lot of waste of laboratory equipment and laboratory workers' time. So a PCR product just, you know, makes everything a lot better. One of the reasons we care about having an accurate test is so we can improve our antibiotic stewardship. I know the CMS, or the Centers for Medicare and Medicaid, and the HHS in America, they're really hammering all the doctors with this. We have a lot of different protocols. And if I diagnose someone with a certain diagnoses, such as a URI or upper respiratory tract infection, bronchitis, anything along those lines, and I give them a prescription for antibiotics, I get dinged. And if I have a certain percentage above what they say is okay, then they will decrease my reimbursement to myself and to the hospital in future years. So everyone's tracking this. They're really pushing this on everyone. So having tests that are accurate is going to help us treat the patients appropriately, and secondarily, you know, help antibiotic stewardship across, you know, all the different medical specialties. I want to say, going back, at least in America, at one point, I think the last research I looked at was 2017, that the population got about 240 prescriptions of antibiotics in that year. And that's for about a little bit over 300 million population. So that's kind of very eye-opening to see that many patients needing antibiotic prescriptions when about 30% of them were unnecessary. So that's millions and millions of antibiotic prescriptions that were just not necessary. This slide just goes over kind of the respiratory seasons. We're now in October, getting into November, so we're kind of hitting all three of them at once. COVID really doesn't have a season yet. If I could see the future, I would imagine it's going to be very similar to this in the future once we get more data. But it's just showing that influenza, RSV, and strep, and more than likely COVID, they all overlap. So all these overlap, and you can't really differentiate one versus another because a lot of the symptoms overlap. So you're going to need a good test that's accurate and can actually differentiate between all the different respiratory pathogens. This is one of the products I'm using, the Expert Express Plus. I call it the quad test. I don't know if that's right or not, but quad meaning 4. So it has the COVID, flu A, flu B, and RSV. So the kind of how we have it set up in my emergency department is the patient presents to the emergency department, they go into triage, they get their vital signs done. If they have any URI symptoms, the triage nurse normally collects this swab, orders in the computer, and sends it to the lab, sends the patient back to the waiting room. And by the time they get placed in a treatment room and I pick up the patient, put my name on them, and decide to go see them, I normally have the results back. So I can treat them appropriately, get them out of the emergency department. It keeps things moving faster. And to have a little impact brief, I can go over some actual numbers of switching over to this test that's actually saved me personally. So the emergency department I'm the medical director at, it's a 30-bed emergency department in a little small town in Louisiana. We see about 60 to 70,000 patients a year and have about 5 doctors a day seeing all the patients. So a lot of the rest of this, I didn't have a chance to update the slide deck before the deadline was due. So a lot of the data on here is about the strep results, but I'll just kind of go over what the differences were for my flu results and how it actually improved. So I'll skip through some of these real quick. This is a lot of the stuff I went over earlier about the strep and center criteria and how we weren't trusting the results of our old test before we switched over to the PCR pathogen. So this is the main thing most hospital administrators, most doctors, most medical directors care about: length of stay and the left without being seen rate. So the length of stay for our flu patients before we switched over was about 150 minutes, and we actually decreased that by 30 minutes, about 31 minutes for all the patients that had flu. So we kind of split it up into group A strep patients and flu patients. So we can just imagine that saying flu instead of group A strep. But when we switched over to the PCR product, our length of stay went down by 30 minutes. That's a huge number in emergency medicine. If you can get patients in and out faster, when we're seeing, over 200 patients a day, 30 minutes on each patient with a URI symptom, that's huge. So what does that normally mean is your left without being seen rate goes down. So all hospital administrators, when they come to the emergency departments, they're going to worry about your left without being seen rate, because that's your money walking out the front door. That's a patient that signs in to triage, they get their vital signs taken, and then they think the wait time is too long and they decide to get up and leave. So a lot of these aren't very sick patients, a lot of upper respiratory pathogen patients. So that's just, something they could collect if you're able to be efficient enough to see them. So by decreasing our length of stay, that then decreased our left without being seen rate by over 1% as well. Our strep, this is our strep data, but our flu results also for our flu patients went down by 1%. So for the whole ER, to monetize that, if an ER that sees about 50,000 patients decreases their left without being seen rate by 1%, that's almost an increase of $1 million in income. So this just goes beyond, it's kind of all facets of, we're treating them appropriately now because we have a better product that we actually trust. They're getting in and out of the ER faster. They're not leaving without being seen or treated. So a lot of times if they didn't get treated, they would go spread it. They might go back to school. They might go back to their nursing home. So it's multifaceted on how everything can change if you have actually a good product. So switching over to that 4-plex plus test, that's the last thing I want to touch on. Is it's a big deal to get all 4 tests ordered at once. We used to, in the old, I say old days, a few years ago, the patient would come in, you'd either order flu on them, flu would be negative, you might order strep on them, that would be negative, and then you discharge them. So now with the option, we have one test, you order it, all 4 results come back, you have 20, 30 minutes for the results to come back, and you can treat them appropriately instead of piecemealing something together, having to order numerous tests all at once. And that's a lot what the CDC and World Health Organization are kind of aiming toward, as well as us getting the tests that can differentiate everything all at once. And if you have a product that can do it all, it's kind of a no-brainer. But it looks like my time's up. So if y'all have any questions, I'll be around as well, but I'll stop my screen sharing and go from there. But thanks for letting me talk.
Dr. Ho?
Yep. Dr. Boyd, thank you very much for a great presentation. So I think it's time for a Q&A from the audience. I will maybe hand it over to Dr. Song. We can pick up the questions together. Yeah.
Sounds good.
Yeah, Dr. Ho, I think we didn't see any question in the Q&A box. Maybe we could directly to introduce the panelist.
Okay, good, Dr. Song. Okay.
Yeah.
Okay, so for the next 35 minutes, we would have a very highly anticipated and thought-provoking topics in COVID-19 and influenza convergence. What is the potential ramifications and actionable insight for the respiratory season? Yeah. So I would like to request our two speakers to stand by. Yeah, just in case there is questions or comment from the audience. So I will move on with the introductions. I take the opportunity to welcome our first panelist, Dr. Rodolfo Pacatipunan Jr. He's the pulmonary medicine specialist, chair of Council of Lung Infections, Philippines College of Chest Physicians. So I would like to welcome Dr. Rodolfo. It was a pleasure. It's a pleasure to meet to have you here. And hand over to Dr. Song. Yeah.
I welcome our next panelist, Dr. Andres Rico Mendoza, professor from SLMC and WHQM College of Medicine, and active consultant, pediatrics and pediatric pulmonary and medicine, SLMC QC and Institute of Pediatrics and Child Health, the Philippines. Welcome, Dr. Andres. So, Dr. Ho, the next.
Our next panelist is Dr. Kenji Ota from Department of Laboratory Medicine, Nagasaki University Hospital, Japan. So welcome, Dr. Ota. It's a pleasure to have you today.
The pleasure is mine. Thank you.
Our next panelist for today is Dr. Megan Rees, working as a consultant physician, respiratory, sleep, and general medicine, Royal Melbourne Hospital, Australia. Welcome, Dr. Megan. So for next 35 minutes, so we have questions for the panelists. Dr. Ho, could you start with the first question?
Yeah, thank you, Dr. Song. So let's start with the first question for our panelists. So the first question will be for Dr. Pacatipunan and Dr. Yanagihara. So as we know that with flu being noticeably absent in Japan and Philippines during the pandemic, do you think it will pose a real problem for us this year? In other words, are we vulnerable to influenza and RSV going forward? And if so, what is the rationale behind that? Maybe I would let Dr. Pacatipunan to maybe share with us first. Dr. Pacatipunan, please.
Thank you. Thank you for inviting us. Well, we don't have a winter season here in the Philippines. Fortunately or unfortunately, what we have are serious rainy seasons where we have those big typhoons. This is the time where we see an increase in respiratory infections. With the surge in COVID in 2021 and 2022, there was a decrease in the coverage of flu vaccinations because people don't want to go out and are afraid to even to receive their vaccines. And the focus of the vaccination in the country was COVID. So with this, we will previously, as similar to what was presented by Dr. Boyd, our coverage for flu, especially in the elderly, are quite high. And the awareness for flu vaccination, they were the ones asking for the flu vaccination among the elderly. But with this, we will see an increase on the flu, especially in the elderly. And although we think we don't have an RSV in the Philippines because based on our observation of the results of our multi-array test, we don't see co-infections that much here in the Philippines. But definitely, with the decrease in the COVID, there will be an increase in the prevalence of flu here in the Philippines.
Okay. Thank you, Dr. Pacatipunan, for your sharing. So I think maybe Dr. Yanagihara, you have additional comment or perspective.
Yeah,
please.
Thank you for your good question. It's very difficult to answer. We show that the two reasons. You may know that we didn't have a full pandemic past 2 years, and now the immunity against the influenza in most people got weaker. So it's very easy to infect influenza. And another thing we have to think about that infection control behavior. If we keep that behavior for COVID-19, we can protect from influenza. But you know that now most people want to relax control measures. So it's risk factor for influenza. So I think about that we have to be careful for pandemic. So we have to do vaccination and we have to prepare that laboratory testing system for COVID-19 and influenza. And another question is RSV. Also, it is very difficult. If we find RSV patient, we do not have that treatment. So if we have that treatment, so very important to pick up the RSV patient. It's some future problem, I think. That is my comment. Thank you.
Yeah, thank you. Thank you, both panelists. Over to you, Dr. Song.
Dr. Song, you are muting.
Sorry. So this question is for Dr. Megan Rhee and Dr. Brian Boy. What can we learn from the flu season in Southern Hemisphere? How vulnerable are we to respiratory infection other than COVID-19? And how should we address respiratory pathogens with similar presentations such as SARS-CoV-2, influenza, and RSV? Please, Dr. Megan.
Thank you very much. Well, I come from Melbourne, which is one of the southern cities in Australia, although I'm here representing TSANZ, which is across Australia and New Zealand, but we certainly experience a cold winter season, not with snow, but pretty cold. And so we do have seasonal flu every year, and we're very lucky to also host the WHO influenza surveillance laboratory in the Southern Hemisphere. So we usually get quite good information about what is likely to come to us, but the last 2 years have been very unusual. So certainly in 2020 and 2021, we had almost zero flu transmission in Victoria, in Melbourne. We were particularly hardly locked down compared to other cities, but we didn't see any flu. So we were quite worried about our flu season coming into 2022. And we were also worried that people would not have much appetite for vaccination against flu, particularly because they've had to have so many vaccinations for COVID of recent times. So there was a very strong campaign for flu vaccination. We did see a quite intense flu season. It came earlier this year than it usually does. We usually have a peak flu incidence in September in Melbourne, but this year it peaked in about June, July. We did see a rise in hospitalizations, and that actually did coincide with a rise in COVID hospitalizations as well. Wasn't as severe as we were concerned about, but we did actually have quite a lot of staff absence in our healthcare facilities. So I guess that's the other thing we have to think about, the patients that present with COVID and flu and their comorbidities, but also your staff that run a hospital can also get unwell in some ways. So I guess in terms of addressing it, I think it's very difficult to differentiate them clinically when they present. So something like a multiplex test where you can simultaneously test for multiple viral pathogens is very useful, particularly if you do have specific treatments, which I guess we do now for COVID. We don't sort of yet have many very effective treatments for the other viral illnesses, but I hope that that is coming in the future. We do have some influenza treatments, but we haven't found that they make a large clinical impact on our inpatients to date. But certainly being able to test for all of that upfront helps with antimicrobial stewardship, helps to get the right diagnosis at the right time and get started on the right treatment approach. Thank you.
Okay, thank you, Dr. Rhee. Next, Dr. Brian Boy.
Yes, sir. So just to touch on a lot of the stuff Dr. Rhee is saying, I'll kind of go over from looking at it from a different perspective for how vulnerable we are to other infections. I think we might be a little bit more vulnerable now because we haven't been exposed to as many pathogens as we have in previous years, with everyone wearing a mask and washing their hands more. So I feel like it could get bad pretty soon. I've already seen more positive flus in the last probably 2 weeks than I have in the last year, and that's just me personally. That it's starting a little bit earlier here in Louisiana and the States as well. But one thing that I'm worried about happening for the vulnerability, not just as a individual patient, but as a healthcare system as a whole, is I know when COVID hit, that we have a huge nursing shortage. They've decreased nursing hours. They've decreased physician hours at most of the sites I've worked at, just because the patients weren't coming in. Most hospitals dropped 20-30% of patient population at least presented to the emergency department, so they decreased coverage in all those areas. And now with this uptick in the respiratory season coming, I kind of already see the writing on the wall that we don't have enough staff, nursing wise, provider wise, that's doctors, NPs, or physician assistants, to be able to handle this, because most of the time hospital administrators are reactionary. They don't hire staff until it's already too late instead of being proactive. So I think it could get bad in the next few months, and that's kind of possibly would be everywhere, but I can't touch on that, just kind of where I'm at. So it's very important to be able to differentiate all the different pathogens as well, but that's just kind of a different take of answering the question a little bit differently.
Okay, thank you, Dr. Boy. For the next question, the panelist, Dr. Ho.
Thank you, Dr. Song. So the next question is for Dr. Mendoza and Dr. Megan Rees as well. So should we be alert for RSV, especially for pediatric populations? Then what are some risk factors? Or have you seen a notable spike in RSV with the COVID wave settling down? So maybe I will let Dr. Agnes Mendoza to share with us first. Dr. Mendoza, please.
Thank you, Dr. Ho. Yes, we should be alert for RSV, and we are seeing quite a lot of RSV in our emergency room. We are able to identify these viruses, and aside from RSV, we have quite a lot also of rhinovirus and human metapneumoviruses. Now, remember that during the pandemic, children stayed at home, and we have this lockdown, so we have very, very few. It's quite remarkable to note that decrease in respiratory infections in children. So now that children are going back to school and people are going around here in our country, then we do see a lot of people having respiratory infections, and the manifestations are quite similar. Whether it's a SARS-CoV-2 virus, a rhinovirus, or a flu virus, the initial symptoms are very similar: upper respiratory tract signs, body malaise, and fever. And it's quite hard to deal with young children, wherein you have to guess what virus is causing this or that. But I think it is very important to note what type of virus we're dealing with, because this will affect the management or how we go about managing this patient. So I believe that our emergency room here at St. Luke's are doing quite a great job in identifying viruses, although it's a bit expensive and not all hospitals have this multi-array. We are using the BioFire here at St. Luke's. So not all hospitals have that, however. So mostly in other hospitals, they're using clinical correlation with a virus. So which is a bit difficult because most viruses would have similar presentations. Yes, I agree. We have seen a notable spike in RSV with the COVID wave settling down.
Mm-hmm. Thank you, Dr. Mendoza. That's a very comprehensive information and important. So how about Dr. Megan Rees? Is there any additional perspective from Australia?
Sure. Well, I would agree. Our experience has been very similar to Dr. Mendoza's in that we certainly have seen an RSV spike this winter, hadn't seen it the previous winters. It didn't coincide with either our influenza or our COVID peak, but it was separated in time, but a peak nonetheless. It certainly occurred in pediatric populations and also those adult populations that deal with pediatric population. So we see quite a lot, particularly in our grandparents of young children who are involved in care of grandchildren, which is quite common in Australia, and also teachers and parents. So it can affect everyone. And again, it does also quite often affect our staff, including, lots of our young adult staff, which nurses and doctors are often in that group. So we certainly have seen a peak. We wouldn't have known that it was an RSV peak without PCR testing, I guess. But it's certainly there, and it is very helpful to know that that's what you're dealing with.
Yeah. Okay. Thank you, Dr. Rees. So over to you, Dr. Song, for the next questions.
Okay, thank you. This question is for Dr. Rodolph and Dr. Ota. Considering the similar presentation in upper respiratory tract infections, if you have to choose between a single plex COVID virus 2 test or multiplex test for COVID virus 2 flu and RSV on a large respiratory panel, what would you choose and how? How does the testing algorithm change with the patient population and variations in respiratory season? Dr. Rodolph?
Thank you for the question. I have an experience on both tests, the singleplex COVID test and the multiplex, because I work in 2 different hospitals. I see the benefit of having the 4 organisms in one test, as mentioned in the previous lecture. It facilitates decision making and triaging of patients in the emergency room. You know where to admit them in the regular room or on the isolation room. But the dilemma with this multiplex test is that not all hospitals in the Philippines have it, and it's a little bit expensive. Some patients do refuse the testing because of the financial burden in the Philippines. But this will definitely change. It facilitates triaging in the emergency room, but it would be very difficult to apply it in the general population due to the financial cost of the testing. It's very important to differentiate the flu from the COVID because of the different treatment and management.
Yeah, I agree with you, Dr. Rodolph. I think it's important to include, this similar presentation. There is a virus infection, but sometimes it's also depend on the facility, the capability, all these issues. So, Dr. Ota.
Thank you for asking me a question. In Japanese situation, I think that depends on the factors like how COVID is managed and how is the epidemic situation other than COVID. I mean, in the situations like COVID is specifically managed with quarantine or isolation, COVID or not is the issue. Therefore, I don't think determination of other pathogens are required in only COVID season. These are the similar situation in 2020s, early phase of this pandemic. But through this pandemic, sometimes determining other pathogen is important. In my experience, my 3-year-old kid had runny nose, and I got multiplex test, and he had rhinovirus, as he has a lot of runny noses. So when someone is an essential worker, defining other pathogen like flu or rhino, sometimes RS can be exclusive of COVID-19, denial of COVID-19, and may lead to social economic activities. So yeah, I think that depends on the epidemic situation and to the target. Thank you.
Okay, thank you, Dr. Ota. I agree. It depends on the policy on the COVID-19 as well as any treatment options for RSV. So if we have the medicine for RSV, I think it's a different issue. So when we try to isolate and diagnose the RSV infection. So next question. next question is for Dr. Yanagihara and also Dr. Boy. So Dr. Boy, in his presentation, has alluded to the implementation and impact of the multiplex test for influenza, SARS-CoV-2, and RSV in the emergency department. How do you see the usage of this test beyond the emergency department in the hospital setting? Dr. Yanagihara?
Yes, thank you for your question. It's difficult to answer. We have to think about the emergency department. As I mentioned my slide, if you find that the severe community acquired case, so we have to check also virus, influenza, SARS, and RSV. So we have to change the medicine. That's very useful. And also that in infection control, if we detect SARS coronavirus too, we have to isolate immediately. So we have to use it. We have to think about influenza. I think all hospital don't care influenza compared to SARS coronavirus 2 now. So, but I think that for infection control, very important in emergency department because there are so many serious patients. So we have to do infection control. So in my opinion, for serious pneumonia, very useful. Also that for infection control are very useful. That is my comment. Thank you.
Okay, thank you, Dr. Yanagihara. Dr. Boy, could you add some comments?
Yes, sir. Kind of going a little bit along this question as well for how do I see the usage of this test beyond emergency departments. The fire department, or my local fire department that I'm the medical director of, has an EMS division, and the EMS division does about 20 runs a year. And during the height of COVID, you know, a lot of people were out. If they had a fever or any symptoms, there really weren't a lot of tests. So we just made people stay at home because we didn't want to be the cause of infecting people in the community. So I actually got a PCR product, one of the Cepheid machines, and got the fourplex test ordered for our local fire department. So if any fireman that was online, EMS, paramedic, EMT, along those lines, if they had any URI symptoms, instead of sending them to an urgent care, sending them to the doctor, sending them to the emergency department, we actually had our own machine and own test and little mini laboratory. You know, since it was CLIA waived, we got everything approved, and we were able to send them to our central station, got them tested, and we could then either put them back online to prevent lost, you know, income and not have to fill it with an overtime slot. So I'm kind of seeing that. I think we should be trying to use these tests in more settings of just the emergency department, you know, maybe to keep people out of the emergency department. So peds clinics, I kind of alluded to, you know, just family medicine or internal medicine clinics in the community as well. If we can get more of these PCR products out there, it could definitely help everyone get the right diagnosis to not have a lot of unnecessary healthcare expenditures. So like aged care settings, that's kind of what I'm alluding to as well, nursing homes, things along those lines.
Okay, thank you, Dr. Boy. I agree, you know, for severe pneumonia, as Dr. Yanagihara mentioned, for severe pneumonia in the emergency department, it's better, you know, to know what kind of pathogen induces pneumonia. Otherwise, we have no idea how to treat them, you know, specifically. I think it's useful information. So next question, Dr. Romy Ho. Yeah, I think, yeah.
Yeah, thank you, Dr. Song. So the next questions for Dr. Agnes Mendoza and Dr. Boyd. So would you consider using the midplex or fourplex test for this SARS-CoV-2, flu, and RSV tests outside the flu season? And what will be the best scenarios for this potential use of fourplex? Maybe Dr. Agnes Mendoza, please.
Thank you for this question. Yes, indeed, it is very practical. If we can just focus on viruses that would be associated with morbidities in our patients, like RSV and flu, and of course the SARS-CoV-2. Because instead of just requesting for too many viruses, like 8 viruses in one panel, then it's not really practical. It's more expensive. But if we can target the important viruses, then indeed I would be happy to use this even outside the flu season. Here in the Philippines, our flu season and the RSV season somehow occurs all year round. No, there's really no specific time because rainy season have changed. Before we used to have rainy season during the August, September, October months, but now it's even in December, January, we have typhoons. Now, as mentioned earlier by my colleague here from the adult pulmonary. So the use of this mid-plex test would be helpful for us clinicians because we want to know and identify what specific virus are we dealing with. So the treatment will be more targeted, meaning to say we can provide a targeted treatment for each of our patients once we identify the virus. RSV would somehow really very bad for children with congenital diseases, and we really have to identify that virus for children with congenital diseases.
Thank you, Dr. Mendoza. So I think that's a very good perspective from your side. I think now diagnostic stewardship is equally important with antibiotic stewardship. A well-targeted test is very important. So how about Dr. Boyd? Maybe you have any additional perspective from your institution or from US?
The only thing I could really add to that would be a lot of times we're kind of hamstrung by what tests we have. I know we had a very big shortage of COVID tests in the middle of the pandemic, and then when we did get some, a lot of times the only test we were able to get was the 4-plex. So it'd be middle of the summer, and the only test I could order was the COVID, flu, and RSV test all in one. Now in the computer system, I could order just the COVID test, and they would run the test, but they would have all the other results. They just wouldn't transfer them over to the electronic health record. They would just result the COVID because that's all I ordered, but we were wasting an entire 4-plex test. So we just kind of do the best we can when situations like the pandemic happen. We kind of do whatever we can that we think is the best. So, I mean, I have been willing to use it just because I was forced to use it, but along those lines, it's always better to only order what you want to order. If in May and June in your country, if there's 0 flu and 0 RSV cases, then there's not a need to waste one of the good products, because you're probably going to want to save those products for the respiratory season when you're going to want to order that on every patient coming in, because there's a much higher likelihood. But that would be kind of the different case scenarios that I would want to use both.
Yeah, thanks, Dr. Boyd. I agree with you. Thanks for sharing your best practice. So next question, I think back to you, Dr. Song.
Yeah, okay, thank you, Dr. Ho. This question is for Dr. Yanagihara and Dr. Ota. How would the testing landscape for upper respiratory pathogens change with the relaxation of border control measures in Japan? Dr. Yanagihara?
Yes, thank you for your question. So testing data change the relaxation border control measures. I agree. And that if you find the pathogens, so we can change. So actually, all doctors don't use PPE. They do not use it. So if you don't find that COVID-19, so they do not use that PPE. So it's I think that testing very useful for that. Very useful to change that relaxation of control measures. I agree.
Okay, thank you, Dr. Yanagihara. Dr. Ota?
Yes, thank you. Well, as a border control loosens, I think that the causative pathogens for upper respiratory tract infection will be more diverse. So it will be hard to diagnose solely by the symptoms. So accordingly, multi-targeted test will be more important, but this is relevant to the treatment option. We do not have so many options against pathogens other than COVID or flu or sometimes RS. So I believe that patient-targeted test strategy, especially to high-risk patients or essential workers, are still important. So I think the basic landscape for your pathogens will not dramatically change. Thank you.
I can have an additional comment. So
Yeah,
you know
okay.
that all the testing, the sensitivity is not 100%. If you don't find the COVID-19, but we have to suspect the patient. But if you find that other pathogens, flu and RSV, so we don't think about COVID-19. It is that one of the good things for multiplex system. Thank you.
Okay, thank you. Yeah, I agree with you. So when the border control, relaxed, I think it will be a dramatic dynamic variation of pathogen detected from population. So it's difficult to see, for each country will be very different. Thank you very much for sharing the comments. So next question for Dr. Romy Ho.
Yeah, thank you, Dr. Song. So I think we have a very thought-provoking questions here for all speakers and panelists. So in the scenario, you have a clinical visions or a capacity to predict, let's say like a imaginary crystal ball. What do you see in the near future regarding SARS-CoV-2, flu, RSV, and other respiratory pathogen? And specifically, how should a healthcare facility and systems be better prepared for the future? So maybe let's start with our speaker first, maybe Dr. Yanagihara, please.
Yeah, thank you for your good question. So yes, I think that if we find that the pathogens SARS, flu, RSV, and other respiratory pathogens, so the system will be changed, because that if you find that the pathogens, we can choose that adequate medicine. Also, we will start at the adequate isolation and infection control. So I think that the detecting that these pathogens very useful for that healthcare facilities and system. Okay, thank you.
Yeah. That's a very good perspective and insight, Dr. Yanagihara. How about you, Dr. Boyd? Dr. Boyd, you might be on mute. Yeah.
No, I was muting. I was typing a response to one of the questions in the chat, but I'm thinking it's going to be, very similar. I kind of alluded to some of this in some of my previous talks, that I think, COVID's here to stay. I think it's just going to be just like another flu for us. We're kind of seeing that as the symptoms, aren't being as severe as we get used to treating it and get a little bit better at treating it, versus where we started, where we used to, intubate everyone as soon as, their oxygen saturations went a little bit low, versus now we have the, they can be hypoxic in the 80s and we're still treating them fine. So we're still learning. But for crystal ball, that's kind of my best guess. Now I'm probably the least smart person on the panel here, so I would have definitely, bow down to the rest of them and their crystal ball. They're a lot more clinical pathologists or clinical medicine doctors that see this a lot more versus just a simple ER doctor. But that's kind of my thoughts on it.
Thank you for your humble thoughts and opinion, Dr. Bo. Okay, now let's move on to our panelists. I think I will start with Dr. Pakatipunan to share maybe his perspective. Dr. Pakatipunan, please.
Yes, thank you. I think we are already seeing the writings on the wall that as COVID is being controlled, we see the emergence again of the other prevalent viral infections such as flu and RSV. So we may need to look back and review our protocols, not necessarily for everybody, but for the most vulnerable ones and those who have higher risk of these co-infections, such as the elderly and those with uncontrolled comorbid diseases, such as diabetes and kidney diseases. But definitely, we have to go back and review this, but it would not be for all, just for those who have high risk of getting the disease.
Yeah, that makes sense, Dr. Pakatipunan. So any additional comment or perspective from Dr. Mendoza, maybe from for pediatric group or for general population as well? Yeah.
Thank you. In the near future, we would be dealing with viruses, variants, all of these types. And it is quite important to know what virus we are dealing with. And I do hope we continue to identify and be aware of these various variants and different viruses that we are encountering. Some of these viruses have been here for such a long time already, older than myself, but I still do think that identification of viruses is crucial in our clinic practice as well as hospital practice. So we should be prepared to deal with more viruses rather than bacteria, because I don't know in other countries whether there's more bacterial infections versus viruses. But in children, very young children, less than 5 years old, we really do have a lot of viruses, more than bacterial infections here in the Philippines.
Yeah, I see. Thank you, Dr. Mendoza. So maybe a next comment from Dr. Ota. Yeah, please feel free to share.
Okay, thank you for asking me the question. It's a little bit hard to give additional comments after these speakers, but I'd like to share my opinion about specimens, because clinical sample collection is another problem to be solved in this COVID-19. So as discussed in the seminar, multiplex test is one of the solutions for sample collection because it can diagnose multiplex pathogens only by single sample. But if we can diagnose other pathogens by saliva specimen, it will be much easier to diagnose these pathogens in more easy to collect specimen. So we need future research about what kind of respiratory pathogens are detected in saliva, and it will be maybe a breakthrough for our respiratory test future. Thank you.
Yeah, thank you. So after we learn a few best practice sharing from US, Japan, and Southeast Asia, maybe now it's Dr. Megan's turn to maybe share additional comment or perspective. Dr. Megan Rees, please.
Well, I guess I don't have a crystal ball, but I have one wish, and that is that the research and the new platforms that we've developed for treating viruses through COVID-19 now spreads on to some of these other viruses, and that we can start to have some really promising and robust therapeutic interventions for different viruses. We'd often previously just put them all together as something that we couldn't really do very much about and didn't have specific therapies. But I think there's an opportunity and a momentum now that we can identify what these pathogens are very rapidly and very readily, and we have some investment in research in this area that we can develop some therapeutics that are specific for these treatments, and not necessarily for or not just for the people that have them, but we're certainly seeing lots of our severely immunosuppressed patients in the hospital are very vulnerable to these infections if they do come into your healthcare facility, if another patient brings them into the hospital. And so it would be very good to have some treatment options for both groups.
Yeah, thanks, Dr. Megan. So just last quick questions before we move to the next session, Dr. Megan. Do you have a specific treatment for pediatric group for RSV infection? Dr. Megan, do you have a specific treatment for pediatric populations for RSV infection?
So no, I don't believe we do. I'm an adult physician. I don't think there are any specific treatments for RSV, no.
Okay, sure. Yeah, thank you. So I think that's all the question for the panelists. Back to you, Dr. Song. I think we have a couple of questions there from the chat box Q&A that we could maybe try to answer.
Yeah, there are a couple questions. Also, some of them are already answered. We can pick up a few questions, and discuss with the panelists. Here is one question I think already answered by Dr. Megan. So do you consider the CT value given by the gene expert machine during the result interpretation, or simply accept the provided result of the machine? For example, is positive or negative? Dr. Megan Reed, so do you have any comments for this question?
So this is referring to the cycle threshold, or so the number of times that PCR needs to go through to get a positive detection. My understanding is that it hasn't really, or we don't think in Australia it's been sufficiently standardized to be part of the formal test result. However, in practice, we do sometimes look at it. The time we use it most frequently is if we're recurrently testing somebody, that we're wanting to know if they're beginning to mount a response to their COVID, or if they're likely to be able to be cleared in the near future. We look to see if essentially there's kind of less virus circulating for that person. So we do look at it in that regard, but it's as a standalone value, we don't yet believe it's there to be reported.
Okay, so thank you, Dr. Megan Rees. Some areas are using the CT, the value as a cutoff, for release the patient from hospital. They use different cutoff, the threshold. Dr. Hu, there's a couple other questions. Dr. Hu, do you want to handle one of these?
Yeah. So there is a questions about during 2 years more of pandemic. Let me see if it has been answered. I don't think it has been answered. Okay, I just want to confirm. Okay, during the 2 years of pandemic, we have intense behavior. Practice using masks on our face for preventing maybe infections. But between COVID-19 cases, with PCR SARS-CoV-2 negative, we found influenza tested by PCR and RSV was negative. What is the cause of this situation? Is it possible that other viruses or bacteria, normal flora in skin cause the influenza? Maybe, this is the maybe questions for speakers. Maybe any similar experience for Dr. Yanagihara?
I don't experience such a case, so I cannot comment. Thank you.
Okay. Yeah. How about Dr. Megan Rees? Do you have any similar experience?
No, I don't think we have seen a similar thing. I don't believe you could get false positives from influenza from normal bacterial flora. I think it's quite a specific test.
Okay. Yeah. Okay, back to you, Dr. Song. Yeah,
maybe we can have one more question for this Q&A, 5 minutes. So yeah. RSV in adult, how frequent? Dr. Boyd, do you have any comments for this? Dr. Boyd is not online.
No, I always keep click unmute. I would assume, I don't know the exact prevalence, but in adults, I would say it's very prevalent, but we don't know the exact prevalence because most adults don't seek treatment for RSV symptoms. They're going to think it's a common cold or stay at home, because it's mainly the extremes of age, the very young or the very old, that we're worried about it. So some of the numbers I just found real quick on the CDC website were, about 2.1 million visits a year on kids in the U.S., and that's, I think, under the age of 5. So it's very prevalent, obviously, in the younger pediatric population. And about 200,000 hospitalizations for RSV in our adult population, and almost 15,000 deaths a year. So I don't know the exact RSV, prevalence, but I would assume it's, it's very prevalent because it's still out there and getting spread, but we don't have enough people getting tested because they're normally not sick enough to need a 4-plex test or anything to, see what they have if they just have the sniffles for a few days, because that's normally all the symptoms an adult patient's going to have if they have an RSV infection if they're not immunocompromised.
Okay, thank you, Dr. Boy. I think that's the Q&A, for the panelists from the, the question from the audience. So now, I saw, Arena has put a web link, to the chat box. So we can ask the attendees to complete the post-webinar surveys through the link provided, posted in the chat box. So I think now we could have a summary of today's webinar. So I will welcome Dr. David Lam and Dr. Romy Hall for closing remarks. Dr. Lam.
Thank you, Professor Song, for sharing this webinars. And I must say, we don't have any crystal balls to see the future yet, but today's seminar is just like a crystal ball, letting us, each of us has a glimpse of what we can do, what to anticipate in the future. And we do all hope that we have a rapid diagnosis for these kind of important respiratory viral diseases, not only limited to respiratory viruses, but could be extended to other pathogens as well. And at the same time, will be precise enough for us because we are anticipating changes in the mutants and the strains of these different kinds of viruses, especially COVID-19, which has not left it completely yet. But today, we do have a very fruitful discussion and have received the very good talks from our distinguished speakers, Dr. Yanagihara and also Dr. Boyd. Thank you to them. And also our panelists, Dr. Pekadipunan, Dr. Rico Mendoza, Dr. Ota, Dr. Rees. Thank you very much for all the discussion. And also thank you to Professor Song for chairing the session, and also Dr. Ho also for chairing the sessions and handling the questions. And last but not least, I would like to say thank you to Cepheid again for bringing these webinars to us with APSR. Thank you very much.
Thank you, Dr. Lam. So now welcome Dr. Romy Hall for the closing remarks.
Yeah, thank you, Dr. Song. On behalf of Cepheid, I would like to thank you, our speakers, Dr. Yanagihara and Dr. Boyd, and Dr. David Lam, and Dr. Song, and the APSR organizing committee, all panelists who have shared their valuable perspective and best practice. And last but not least, of course, our audience for attending this webinar. I believe today we have reviewed and learned how diagnostic stewardship is equally important as antibiotic stewardship and has a significant implication in achieving fast, not only fast, but accurate and cost-effective clinical decision-making. As we know, as our speaker said, that the right management depends on the right diagnosis of each pathogen. So have a great day ahead, and I hand it over back to Dr. Song to formally close our session. Thank you.
Okay, thank you, Dr. Ho. So again, I think Dr. Lam, Dr. Ho, and also our two speakers, Dr. Yanagihara and Dr. Boy, for the two very good presentations explaining the current situation for the COVID-19 and also other upper airway virus infections such as RSV, etc. And also thanks for the panelists, expert, for the virus infection, Dr. Rodolph, Dr. Mendoza, Dr. Ota, and Dr. Rees, for the discussion, for the various questions. Also thanks Serena, for the preparation of this webinar and the APSR, our working staff. Thanks again. I think that's all the time we have for today. And see you soon in our next webinar of the series early next year. And thank you again for joining us, and have a good day. Bye.